Let's start.
Everyone's here, right?
All right, so remember, for those of you who weren't completely brain dead after the test last week, we talked a little bit about routine OB care, and then we had to stop. So let's pick up where we left off, which was basic complications of pregnancy. We've gone into the third trimester, and you can review the video. It's up there on YouTube for you to watch when you're more well rested. So, third trimester, the big problems that we worry about is gestational diabetes. We actually talked about these things. Gestational diabetes and how it's insulin resistant, and how pregnant women take like 100 units of insulin. But usually we use just plain old metformin. Placenta previa, which is painless vaginal bleeding. Placenta abruptio, or abruptio placentae, which is painful vaginal bleeding. And how a very important, crack is whack, yeah. How very important it is that you will get painless vaginal bleeding, and you will automatically assume it is placenta previa, and you will probably be right. And you will get a woman having incredible pain and vaginal bleeding, and you will automatically assume it is abruptio placentae or placenta abruption, and you will probably be right. Okay, those two are covered on every exam in obstetrics, every NCLEX, every time you're going to a nursing function in labor and delivery. I mean, they just love asking that question. And then the big problems of the third trimester for the baby is hypoxia. Hypoxia either chronic or acute, okay? So if you've got a baby who's hypoxic, what could be making a baby hypoxic? Why would he not be able to breathe? Cord, okay? So acute cord compression, right? Problem with Wharton's jelly, where the cord allows itself to compress on itself, or a true knot in the cord, where it's impeding blood flow. Good. What other problems would give a baby hypoxia? A little further away from him than the cord. The placenta, exactly. Placental insufficiency causes hypoxia, right? Think about the placenta as the baby's oxygen tanks. He's a scuba diver, he's underwater, and he's got this oxygen tank on his back. It's called a placenta, right? And that oxygen tank is allowing him to oxygenate his tissues through his maternal circulation. And so babies who have a problem in their placenta have a hard time growing. And there are 1,000 things that can cause problems with the placenta. Like high blood pressure can do it, diabetes can do it, smoking can do it, cocaine can do it, genetic instability can do it. By the way, for the cocaine. No, but
Cocaine!
well, there are a lot of pregnant women on heroin, but there are an awful lot of pregnant women on cocaine. Yeah. But all these things can cause, being at a high elevation can cause hypoxia for babies. So all these things can cause hypoxia, and they're going to affect the baby. And when they do, it's almost always in the third trimester, okay? So it's just important to know that. We're going to cover it more later. Now, this is a template. It's in your book about about what is routine OB care. This is just a sample of their practices, routine OB care, okay? And you see how it breaks it down by weeks. 8 to 18 weeks, 24 to 28 weeks, 35 to 37 weeks, and then postpartum. And you can whip out the magnifying glass and read this if you like. But most times we have a prenatal care map. It looks something like this. Okay? This is the care that is done, and this is the education that is done. Okay? As a general rule, prenatal care is done targeted based on the part of the pregnancy that they're in. So you don't talk to a woman at 12 weeks. You don't say the same thing as you say to a woman at 38 weeks, right? So I mentioned last week that the Army remade, or the Department of Defense rewrote all their prenatal care map, and it ended up looking something like this. This came out after the Army. Okay, this is 2008. The Army did it in 2001. We currently, most people will do a 10-week or 10-visit protocol for pregnancy. With the first visit with a provider is the new OB visit. New OB visit, we want to establish pregnancy. We want to make sure we know what her due date is. We want to screen for disorders. And from the nursing perspective, we want to teach. We want to teach about all the things that are happening to her in the first trimester and give her a little bit of a preventive a little bit of anticipatory guidance. If you remember last week, I gave you guys my prenatal spiel about safety, exercise, breastfeeding, nutrition, weight gain, I talked about that, okay? The second visit is somewhere between 16 and 20 weeks. That's the time when the baby is formed enough that we can see him by ultrasound and get a pretty good look at him. And it's also a great time to screen for chromosomal anomalies and that sort of stuff. So at 16 to 20 weeks is when we do a fetal survey by ultrasound. All the parents care about is that they can see the baby's gender. But what we care about is, does he have a 4-chambered heart? Does he have 2 kidneys? Does he have 3 umbilical vessels? Does he have a brain? Does it have cysts in it? Does it have holes in it? Is there a problem with his brain? Does his umbilical cord go all the way into his abdomen? Or does it stop out here and he's got a gastroschisis or something like that? Does he have 4 limbs? Does he have 10 fingers and 10 toes? Those kind of things are what we're looking for, okay? It's between 16 and 22 weeks, babies are big enough to see them on ultrasound, but not so big that we can't see what we're looking for. Because as they get bigger, they get harder to see by ultrasound. Okay, because ultrasound is kind of like a telescope, and like we can look through and we're like, aha, I see you. But if I get up real close to you, all of a sudden all I can see is your elbow. And I'm like, I can't see her very well, right? And so the bigger baby gets, the closer they get to the ultrasound, the harder they are to see. So we like to see them between 16 and 22 weeks. But it's also time for us to do our alpha fetal protein screening, or you might see it, right? You might read it as a quad screen. A quad screen looks for, there are several tests. There's a 3 screen, a 4 screen, and a 5 screen. It looks for various hormones. And they give us an indication that there might be something wrong with the baby, like Down syndrome, Edwards syndrome, Turner syndrome, spina bifida, anencephaly. We can see all those things by a maternal lab value. So we draw her blood, and we measure the hormones in them, the placental hormones in them, and they can tell us whether there's a problem whether or not there might be a problem with baby. Now those are often wrong. They're just screening tests, both the ultrasound and the lab value. So you would never do a quad screen and have it come back positive for Downs and say, your baby has Down syndrome, we should abort. You would never do anything like that. And just like you would never say, you have high blood pressure, you need heart surgery right away. Okay, you would never do that, right? It's a screening test. And then you use that to build more information. So that's like a checkpoint so we can refer them to perinatology for more detailed fetal surveys if they need them, okay? Then right around 24 weeks, now what magical thing happens in the baby at 24 weeks? He becomes,
No,
what?
it's 26, never mind.
What were you
I
going
was
to
going
say?
to say he's able to survive on something, but it's 26.
It's actually 24.
Oh, okay.
So 24 weeks is what we call viable, okay? Now we're worried about preterm labor, right? Before 24 weeks, if she went into labor, I sure do hate it for you, but there's not much we can do, okay? 24 weeks, now there's something we can do for you. So we start talking about preterm labor precautions, and we start talking about well, primarily preterm labor precautions. And we review, you know, her risk factors up until there, okay? And so preterm labor precautions, as a general rule, we talk about if you have more than 6 contractions in an hour, despite resting and drinking a liter of water, you should come in and be seen, okay? Reminding every woman that everybody contracts from 20 weeks on, but there is a difference between your rhythmic, warm-up type contractions that your uterus is going to do your whole pregnancy and those that cause labor. And the big difference is more than 6 in an hour, and they don't go away when you rest and drink water, okay? Those 2 things signal preterm labor, okay? Doesn't mean it is, but they really make us worried about it, okay? The number 1 reason why pregnant women contract pathologically in pregnancy is urinary tract infection. Number 2 reason is dehydration. Number 3 is stress, okay? So the first thing we do is say rest, drink water, relax, let it go, and if it doesn't work, you come on in and see us and we'll rule out a urinary tract infection, okay? Did you guys notice in the Fayetteville Observer, WOMAC was mentioned? Did you see it? They did a big article in the Fayetteville Observer last week on WOMAC because one of our residents did a study. He did a preliminary study a few years back, and then he did a follow-on study that he just published that showed that when a woman's husband deploys, her risk of preterm labor goes up 300%. Wow. Talk about the effects of stress on preterm birth, right? 3-fold increase on preterm birth if a woman's husband is deployed. That's an impressive number, okay? So we know that stress makes contractions. We know that stress causes preterm labor. And so So that builds a lot of, that's a powerful finding. And it also leads credence to the other things, talking about other stressors, like social stressors, causing maybe a source of preterm birth in the African American or the minority communities. It adds stressors, it adds credence to preterm birth in all the homeless population. So we know that stress causes that. So we talk a lot about relaxing and calming down and letting, kind of doing relaxation exercises and that sort of stuff. Okay, 28 weeks. Now we've reached the point of maximum hemodilution in the blood volume. Mom's blood volume has gone up 50% like it's supposed to, or her plasma volume, and now we have completely diluted her blood vessels, right? Or her bloodstream. So now is a great time to look for anemia and diabetes. Okay, so 28 weeks is when we screen for anemia and gestational diabetes. And did you guys read how we screen for gestational diabetes? They take a drink.
Oh, yeah.
Yeah, they take at 28 weeks, they take a glucola challenge. We give them a big boost of glucose, and then we test their blood an hour later to see how their body responded to it. If the blood sugar is real high, it means we need to do more testing. If it doesn't go up real high, then we know we're okay, that her body can respond appropriately. Okay? Then, go ahead.
What was the other one? It was gestational diabetes. What was the other one?
Anemia.
Anemia. Okay.
Yep, hemodilutional anemia, which is a normal finding in pregnancy, but if the hemoglobin drops too low, we want to boost her hemoglobin up with more iron, right? Then 32 weeks is when we start talking about birth plans, because there's not really much going on at 32 weeks. And then 36 weeks, we finalize birth plans and start thinking about when do you want to have your next baby, what are your contraception choices. And then 38, 39, and 40 is feed and grow time. We're just waiting for mom to go into labor, okay? At every visit, we discuss breastfeeding, and at every visit, we want to know her height, her weight, her fundal height, and her fetal heart tones, okay, at every visit. Okay, and we track those as they get more pregnant. As a general rule, the fundal height, when we measure from the pubic bone to the top of the uterus, should always equal the number of weeks she's pregnant, give or take 2 centimeters. Okay, so she's 34 weeks, we measure her fundal height, we get 32. We're like, okay, good stuff. Come back in a couple weeks, we'll see you again. Okay, if we measure it and it's 40, then there might be something unusual going on, right? So again, it's another screening tool. Now, let's talk about centering pregnancy. Do you notice a difference between what we just saw here and what we see here?
It's very colorful.
Very colorful, and that's on purpose. Okay, and those are girl colors.
Those are girl colors.
That's pastel. That's pastel till you puke. So centering pregnancy is an alternative form of pregnancy care. It is not a support group, but it uses support group philosophy in its pregnancy care. Okay, what we do is we come together with a group of women or a group of families who are all due at around the same time, and we spend 2 hours together in a circle talking about pregnancy, about whatever happens at the time. Okay. Now there are 13 essential elements of centering that define what it is. That the health assessment occurs within a group space, meaning it's not one-on-one with your provider. Okay. We do spend a very small amount of time, what we call mat time, where the mom and dad can get with the provider, usually behind a screen, and they can talk a little bit about, like, measure the fundal height, listen to heart tones, I got gonorrhea and I need to treat it, I don't want the rest of the group to know, whatever, okay? But in general, all the health assessment is done in the group. Why? Because all the women who are 34 weeks pregnant are experiencing the exact same thing, all of them. And so as a healthcare provider, when I'm doing my routine OB care and I see 10 women at 34 weeks, all of them for 15 minutes at a time, every 15 minutes I'm seeing the exact same thing over and over and over again. And I'm wasting a lot of time, right? It's frustrating for me because I keep saying the same thing over and over again. And if I had more time, I could expand on it. That's the value of centering, because I can expand for 2 hours because all the women are 34 weeks. And they all need the same basic education. So centering is a really keys in on education. Participants are involved in self-care. They take their own vital signs. They take their own blood pressure, their own pulse. They record it in their own chart. They step up on the scale and record that themselves. They do their own care. Okay? All we have to do is make sure they're doing it right. We teach them a little bit up front. We monitor from time to time, and that's all. Okay? So they provide their own care, which is really neat. It's a facilitative leadership style. So the facilitator of the group doesn't teach. The facilitator of the group says, what's going on? What would you guys like to talk about this week? Oh, so you've experienced preterm contractions? Why don't you tell us about it? You know, they just keep the conversation going while the group works it through themselves. Each session has an overall plan, it does, where by no means do we have to follow it. But each session has a plan, and we would like to follow if the group will allow us to follow it. The attention is given to core content, although the emphasis varies, 5 and 6 go together. There's stability in group leadership. They see the same provider every visit, okay? You know your centering group very, very well by the time it's over. And there's always, in most people have a facilitator and a co-facilitator. Usually it's a provider and a nurse, okay? You conduct, group conduct honors the contribution of each member. You know, it's a group, so you don't let somebody just sit there and never contribute, and you never discuss, you never discount anything anyone's talking about. Composition of the group is stable and not stable but not rigid. People who start the pregnancy together usually end the pregnancy together, but sometimes people PCS, sometimes people deliver prematurely, whatever, there things happen. I mean, sometimes they just realize it's not for them and they need to spend more time elsewhere. Group size is optimal to promote the process, meaning you don't have a group of 100 couples. Usually it's 8 to 10 couples. Involvement of the family support, you notice I keep saying couple, not mother, right? It's the husband and the wife together. It's the partner is in the care too. Because no one's going home with mom except dad, right? Whoever the partner happens to be, that's who's going home with them. And so that person needs to know as much as she does. Opportunity for socializing within the group is provided. What's really cool is these people become very good friends. They become Facebook friends, they give each other rides, they do play groups together afterward. It's a wonderful support network, especially for a military community who are always all on their own, you know, who are separated from their families. And that there's ongoing evaluation of outcomes. We're constantly doing it over again. Over here are the themes that we do. And they're very similar to what I just discussed about, you know, preterm labor at 24 weeks and, you know, 30 weeks, or 32 weeks, we talk about birth and contraception, that kind of stuff. And I posted an article for you guys to read a little bit about it. What we know about centering is the patient satisfaction scores go through the roof. It's almost 100% every time. Their breastfeeding success rate is very high, and their preterm birth rate is dropped by 1/3. So it's pretty darn cool. Well, the average, national average for preterm birth is 10 to 12%. Among centering patients at WOMAC, it's 4%. Pretty darn cool, right? That is despite husbands being deployed, which is a 30% preterm birth rate. So it's pretty darn impressive. And the follow-on study is, does centering actually decrease preterm birth in husbands who are deployed, or women whose husbands are deployed? That's the next study that they're going to be doing. Okay, pretty good stuff. Childbirth education. The key is to promote a positive childbirth experience. Did anybody watch any of those interviews that happened over the summer that I kept posting on Facebook? Anybody watch any of them? Like Penny Simkin was interviewed, and Michelle Odent was interviewed. No? 30 interviews from the world's foremost experts on birth. Every single one of them said number one was the most important thing. Okay? Promoting a positive birth experience for that woman is all that matters. And it doesn't matter how you do it, as long as that woman has a positive birth experience. Which means 23 of you in the room, all 23 of you will have different birth experiences. And it doesn't matter how you do it. All 23 of you who have babies will have a different birth experience. And it doesn't matter what the experience is, as long as it's what you wanted. Or as long as it's what you feel was supportive. That's all that matters. And so all childbirth education is finding a way to create a positive childbearing experience. What I think is funny is when you did your childbirth education, did they not, those of you who have had children who took childbirth education classes, did they not talk about pain and fear and surviving the experience and how awful it was going to be over and over and over again? And they call that positive childbirth experiences. Absolutely not. I look at it so very different. Okay, and the topics include these things. Okay, basic comfort measures, basic anatomy and physiology. Yes, you have 3 holes. That kind of stuff. It all needs to be covered. Okay. Now, I talked about there are different options. There are at least a dozen. I gave you a few of them. Lamaze, Bradley, Grantley Dick Reed, hypnobirthing, Lavoie, Odent, birth from within. It goes on and on and on. Okay, there's conscious birthing. There's water birthing. There it goes. There's dozens and dozens of options, and we're going to talk about those more tomorrow. Okay. Finding information from childbirth education. They say the healthcare providers, unless they're midwives, are just awful at giving childbirth education. They really are. They're the gatekeeper. They are the ones who say the hospital offers childbirth education, and it's every Tuesday and Thursday from this time to this time. That's about as close as most childcare or healthcare providers will get. But they're the gatekeeper. They refer them to it. Of course, there are thousands of online things that you can do. You could Google, you could ask friends and family. The important thing is finding ways to make it a positive experience. Okay? The birth plan. There was a wonderful human rights lawyer was interviewed over the summer as part of this series. I can't remember, I'm blanking on her name right now. I posted it on Facebook at the time. But she's a human rights lawyer, and she said the birth plan should only say one thing. I expect to be fully, what was it? I expect to have complete, the consent form? Informed consent. Complete informed consent and to be supported in my decision making. Okay? That's what all childbirth plans should be. Something along that line. They're not. I don't want an episiotomy. I don't want this. I don't want this. I do want this. I do want this. I do want this. But if everything goes wrong, that's okay. Well, as long as I survive. That's not really a very good birth plan. Okay? But as a general rule, birth plans are written plans where they talk about the things that they would like and things that they would not like to kind of help the provider to understand. Yes, I want delayed cord clamping. Yes, I want immediate skin-to-skin contact. I want to push only when I feel like pushing. I want to be coached through the push. I want my water to break naturally. I want you to break my water. I want an epidural. I don't want an epidural. I want narcotics. I don't want narcotics. And if you do, spend 5 minutes on Google looking for birth plans. You'll come up with some kind of a set of birth plans, like a checklist birth plan thing, and you can check off the things that you want. I always discourage people from showing me those, okay, because they almost always contradict each other. I want the freedom to move about as I want to, and I want continuous electronic fetal monitoring. Sorry, you can't have both, because the fetal monitor doesn't move very well with you, Or I want narcotics, and I want to be able to move around. Can't do that, you'll fall. Okay? I want an epidural and I want to move, or whatever. I want to push naturally, but I want an epidural. Sorry, the epidural makes it very hard to push naturally. That kind of thing. But it's a good starting point. It gives a good framework for them to kind of like make a rough draft, and then they can come and talk to me about it, and we can hash it out. Okay? Have we not talked enough for a break, or should we take a break and get back on? You know what, let's give another half an hour, then we can have one more hour after the break, okay? So now we're on to chapter 11, okay? Complications of pregnancy. Early pregnancy complications. So this works just like all the rest. It starts the first trimester, runs through second, runs through third, okay? So the most common early pregnancy complication is pregnancy loss, okay? Miscarriages, ectopic pregnancies, molar pregnancies, okay? So, anyone know how often do miscarriages occur? What percentage of pregnancies end in miscarriage?
Every 1 in 4.
Anywhere from 1 in 4 to 1 in 2. Depends on who you ask. There are some experts that suggest that every time you're a week late on a period, it's because you had a miscarriage. Okay? That you were pregnant, but the pregnancy failed very early. But the most commonly accepted is about 25% of pregnancies end in miscarriage. And why is it that 25% of pregnancies end in miscarriage? What do you think? Because it's hard to make humans, that's why. We're just a complicated species. And if there's anything at all wrong, the body will stop and start over again, okay? So it runs through, about the cellular duplication or replication process, about how cells realign their chromosomes and do a quick check, and if anything's wrong, the cell goes to apoptosis, right? Same thing happens in fetal development. If there's anything wrong, the body recognizes it and rejects the pregnancy immediately. And so most first trimester losses occur because of some genetic mismatch, some chromosomal misalignment of some sort. Okay? Ectopic pregnancy. What is an ectopic pregnancy? It's in the tubes, exactly. Technically, ectopic pregnancy means a pregnancy where it doesn't belong. So it can be in the tubes, and most often it's in the ampulla. If you guys remember, the ampulla is the cone shape at the end of the tubes. Okay? It's most often in the ampulla. But an ectopic pregnancy would also be a pregnancy outside the uterus altogether, in the abdomen. Okay? Those are very rare these days because of our early screening that we do. We treat it as an ectopic pregnancy very early, and we terminate the pregnancy as fast as possible. But in 1990 and 1991, we had 2 heterotopic pregnancies at Womack. I mean, not at Womack, in Landstuhl, where women transferred in from Spain. They had a full-term baby outside the uterus, and the placenta was connected to the intestines, and that's how it was surviving. And so they deliver by C-section, deliver the baby, leave the placenta in there. Okay. The first one, they tried to get the placenta off, and the woman almost bled to death. The second one, they left it alone. And it was a funny story because the second time, like whenever something like that happens in Europe, the doctors will call the big house here in America. They'll call like Walter Reed and say, Walter Reed, what do we do? And Walter Reed has all the experts, and so they give them their best opinion. The first time it happened, they gave them their best opinion. They went with it. Okay, fine. The second time it happened, they called Walter Reed, and Walter Reed said, why are you calling me? I've never seen one of those. You're the only person in the Army who's ever seen it before. Go right ahead and do whatever you want to do. You don't know. I don't know.
Yeah.
Isn't that interesting?
Wow.
And just by coincidence, the doctor who oversaw both of those pregnancies works at Womack right now. Yep. His name is Dr. Conrad. He and my wife were friends back in the 80s. Anyway, what's that?
Did he take pictures?
No, and he never wrote it up, the no good slime ball. He should have written it up. He could have been famous. Anyway, he was a general practitioner. He was just too busy. So, and then there's gestation, but ectopic pregnancy is a life-threatening complication for women, okay? Because if it gets in the tube and it ruptures the tube, a woman can bleed to death very quickly. The mantra in obstetrics is you only get one chance to miss an ectopic pregnancy because they come back dead. Okay, they bleed to death. Women bleed to death very, very quickly. You can treat them surgically, or you can treat them with methotrexate. Most of the time, we try methotrexate first. It's a chemotherapy drug. It terminates the pregnancy and makes it shrink down so that it doesn't happen again. And the big thing about ectopic pregnancy is that once a woman has had an ectopic pregnancy, she is at a significantly higher risk of having another. Okay. Then there's gestational trophoblastic disease. Anyone know what that is or why there are so many things after it? What does it sound like? Okay, it is a pregnancy complication, yes. Trophoblastic?
Something's wrong with
Something with the baby.
Sure. So it's a pregnancy in the trophoblast, right? Or it's a pregnancy complication in the trophoblast, and it is malignant. Okay, it's a form of cancer that happens in pregnancy. What happens is egg and sperm unites, and instead of forming a baby, they form a cancerous tumor in the uterus. Okay, and it runs a spectrum from a benign molar pregnancy, which just it's not a pregnancy really at all the way up to uterine cancer. Okay, and it can be very, very deadly. You guys hear about that woman in Fort Drum? A year or two ago, had twins, and then 6 weeks later was diagnosed with uterine cancer, and ended up dying like 6 months later. No, yeah, pretty common. But that's just it was all over the news. Anytime a woman who's 6 weeks postpartum with twins, and she dies, everybody freaks out about it.
Yes.
Yeah.
But was there any ethnicities with this? Like I thought it's...
Asians,
Right.
especially Japanese.
Yes.
So the risk is about 1 in 1,000 for gestational trophoblastic disease. Among the Asian population, 1 in 100. Very, very high. Yep. And it's a spectrum disorder from partial molar pregnancy to complete molar pregnancy, all the way through to cancer.
Some of my
But-
family had this type of pregnancy.
Yeah. but it's vaginal bleeding and excessive uterine growth, and then nausea and vomiting like crazy. You see a woman with hyperemesis gravidarum, we always want to make sure it's not gestational trophoblastic disease. If you run their HCG, a quantitative HCG, where a normal woman at about 6 to 8 weeks is like 150,000, they'll be 1.5 million HCG. Yeah, and their HCG is off the chart crazy, because instead of a baby forming, there's this rapidly growing tumor. And so at 12 weeks, they've got this 18-week size uterus that's nothing but tumor, you know? Yep. And the only thing you can do is empty the uterus. Now, my wife actually had a partial molar pregnancy with baby number 6. Yeah, baby number 6. And that's where the baby has 69 chromosome pairs instead of 46 or whatever. So it's called triploidy. And the baby forms kind of humanoid, but the placenta has the tumor in it. And they survive until about 18 weeks, and then the placenta is more tumor than placenta, and it doesn't support the baby anymore. It's a horrible, sad, awful thing, and all you can do is a D&C. But these women are at significantly increased risk of having another one, and they're at higher risk of having uterine cancer the rest of their life. So it's a big deal. Then there's spontaneous abortion anytime before 20 weeks. Symptoms include bleeding, cramping, abdominal pain, and they all of a sudden stop feeling the baby move. Okay, so they stop feeling pregnant. And it says management is the D&C. That is not the first option. Okay? We first try to give a medication to encourage a miscarriage to happen. We give them Cytotec, that same drug we use for postpartum hemorrhage. Okay, about the same amount, 400 to 800 micrograms, and see if that'll work. And if that won't work, then we talk about a D&C or just allowing it to go naturally. Cervical insufficiency or incompetent cervix usually happens somewhere between 16 and 20 weeks. For some reason, and we don't know why, the cervix is just incompetent. And what is the cervix's primary job? To keep the baby in. Okay, nourishing the baby is the placenta. But it keeps the baby in, right? It's the tight muscle that holds the uterus closed. And if it's incompetent, guess what happens? It doesn't hold the uterus closed, right? And unfortunately, baby falls out. And it's terrible. There's a lot of controversy about how to treat it. You can sew the cervix closed, it's called a cerclage, or you can put somebody on complete bed rest. Neither one of them is better than the other, okay? What we do is we watch every week or so, we watch with a transvaginal ultrasound to measure the cervical length. If it starts to get more short, then we take it to the next level. But a cervix should be 3 to 5 centimeters long, and when we do our 18-week ultrasound on the baby, we notice a short cervix. That's usually what keys us in. Or mom will have this cramping, bleeding kind of thing, and we'll do a cervical ultrasound. We're like, oh my gosh, her cervix is paper thin, and that's just bad. It's an incompetent cervix. But bed rest and cerclage are the only 2 options, and they're both equal. They both work, sort of, but one doesn't work any better than the other. There's hyperemesis gravidarum. Any idea what that is?
A lot of vomiting.
A lot of vomiting in pregnancy, right? It is persistent, ongoing, all the time, every day. It usually is associated with some weight loss if it's severe. And a woman can lose up to 7 to 10% of their their total pre-pregnancy weight before we really start worrying about it. As a general rule, all we can do is support them with fluids and antiemetics as possible, but every antiemetic seems to cause problems. Thalidomide was an antiemetic cause problem, DES an antiemetic that caused problem, and now Zofran, our favorite antiemetic, it's causing heart defects. So it seems like every time we try to come up with an anti-nausea medicine, it doesn't work very well.
Are they still prescribing Zofran though? Because
Yes, but it's moved to a class D drug.
because every patient, even the maternal clinic that I saw last week,
Mhm.
so I saw like 5 patients, and 4 of the 5 were either prescribed Zofran or
Yeah.
were on it at some point.
Yeah, it was a very popular drug up until about a year ago. Then it started to get a bad reputation, and then now it's got a horrible reputation. And it's one of those things where, yeah, I can give you Zofran. It is going to double your baby's risk of heart defect. Do you want to try? And so that goes from a 1% to a 2% risk. So it's not like it's a 50% risk, but it is a higher risk of heart defect when you're on Zofran. And the key is to avoid starvation, okay? My general rule is if they go more than 24 hours and they can't tolerate anything by mouth, they need an IV. And I'll give them D5W, 1 or 2 liters or so, and some Phenergan and send them home. And, keep trying. Now, there's an awful lot of non-pharmacologic stuff we can use. There's an acupressure point on your wrist that makes nausea go away. You know that line right there on your wrist? If you take 3 fingers, start on that line, 1, 2, 3, and then see when you squeeze, see there's little cables in there, right? Press down between those 3 cables, right there, with that 3rd finger, and it makes nausea go away.
They make the C-bands, the wrist.
They sure do. Yep. That's what C-bands were invented for. It was discovered by British sailors back when Britannia ruled the waves. They went to Singapore. They found this acupressure technique that made nausea go away. So that you can't sail a ship doing this. So they had to put little bands on their wrist with pressure. So now they have these elastic bands with a little button that you wear on your wrist, and it makes nausea go away. Very good for hangovers, by the way.
Yes.
Very good for hangovers. Very good for seasickness, flying. Very good for anything that causes nausea, and it works pretty good for pregnancy. Also, ginger works really well. Ginger ale, ginger root, ginger pops, ginger snaps. Ginger works very well for nausea as well.
The magnets?
Magnets, I've never used them, but there's magnets that go back here. There's moxibustion. There's all kinds of stuff. Yep. B6, thank you. B6 and Unisom.
Yes.
It's called Bendictine. It is the only medication that has been proven to decrease nausea, vomiting in pregnancy. B6 and Unisom. Midwives have been using it since the beginning of time. But vitamin B6, plain old niacin, I think it is, and Unisom is a sleeping pill. Okay, very closely related to Benadryl, by the way. Unisom, it alters the brain chemical. It's generally a B6 in the morning and a B6 and a Unisom at night, and that works. The FDA just approved a new drug. I can't remember what it's called, but it's B6 and Unisom. But you only take 1 dose a day, and it's got a long-lasting thing. It's got an SR in the name, and it costs like $60 a pill, where B6 and Unisom cost 30 cents.
Right?
Yeah. And then, of course, small, frequent meals, trying to avoid things that are known nausea triggers, and high-protein snacks. Obesity in pregnancy. Any woman whose body mass index is greater than 30 is obese in pregnancy, okay? And if their body mass index is greater than 40, they're morbidly obese, okay? Not that they're gross, that it's morbid, it's that it's more likely to cause morbidity, okay? So they're at increased risk for all these things. C-sections, induction of labor, gestational hypertension, preeclampsia, HELLP syndrome, gestational diabetes, heart disease, DVTs, blood clots, postpartum hemorrhage, and death. It is a very, very bad thing to be pregnant if you're morbidly obese. Very, very bad. Hemorrhagic disorders. Here we are again. Placenta previa, placenta abruption. Can you get the idea that this is important? Right? Placenta previa and abruption? Yeah? It's like the 16th time we've mentioned it. Okay? There you go. Crack cocaine! And the important thing about it is recognizing the difference between the two of them. Now, when I was in undergrad and I was studying this, and it was like, oh, I'll remember, pain less bleeding is placenta previa, painful bleeding is abruption. I got it. As a healthcare provider, the two are so very different, I'm shocked that they're even mentioned at the same time. Okay? They are so very different. We recognize placenta previa very early in pregnancy by ultrasound. Okay? Definitely by the 16 to 20 week ultrasound, we know exactly where the placenta is. And it's not uncommon for it to start kind of low and then creep its way up the uterus as the uterus grows. And so most placenta previa will resolve on its own if it's not a complete previa. But a partial previa, where it's just kind of low-lying or touching the cervix, it'll resolve on its own. Okay? Complete previa actually covers the whole cervix, and that bad boy ain't going nowhere. Okay? A woman with placenta previa knows that she has placenta previa. Okay? Everybody in the hospital knows she has placenta previa. It is a huge problem. And if they get a drop of blood, they run to the hospital as fast as possible, okay, for evaluation. So they spend their entire pregnancy on modified bed rest and pelvic rest, which means nothing goes in the vagina, nothing in the pelvis at all. No boys, no toys, no nothing. Okay? And that certainly does suck, but it keeps them from dying. We don't want anything bumping into the cervix, okay? Not that they can't have orgasm. They just can't have anything in the pelvis, okay? And then there's abruptio placentae, or placental abruption. Placental abruption is a traumatic separation of the placenta from the uterus, okay? Placenta previa, we know about it, we're watching it, we got it. Placental abruption is a lightning bolt out of the blue, nowhere, we didn't see it coming, okay? It is most often caused from trauma, all right? Not being punched or kicked, but this one. That's it, okay? It's the jarring motion that makes it happen. Because what happens with physics, okay? You've got a 30-pound uterus and a 3-pound placenta, right? So they fall at different paces, at different speeds, okay? And they stop moving. One has more inertia than the other. So these two things are falling. They hit the ground, like she slips and falls on the ice. She falls downstairs, something like that. They're falling. The placenta stops moving, and the uterus keeps moving, okay? And it bounces, and then it comes back up again, while the placenta does a little bounce and comes back up again, right? And that shearing motion between the two causes a separation of the blood vessels where the placenta connects to the uterus, okay? And that shearing motion, and it causes a little bit of a blood, and the blood will build up between those two layers. Now, the placenta can handle 50% abruption before the baby will start to really complain about it. Half of the placenta can come off the wall, okay? And what happens is, when it happens inside, you just get this little bruise that kind of forms in the uterus, and then the pressure will build up around it and stop the bleeding through direct pressure, okay? Those women, any woman who gets in a car accident, any woman who falls, any woman who has any kind of trauma in pregnancy, especially in the third trimester, needs to be immediately transported to labor and delivery for monitoring, okay? They'll get contractions for a couple of hours, and then they'll usually go away, all right? And that means she did not have a placental abruption. But, and if you're going to have a placental abruption after trauma, it's going to happen within 4 hours of the injury. So what always happens is women fall downstairs, and then 3 days later they warn me, they tell me about it. And I go, well, I wish you had told me about it when it happened, because if you had died, I wouldn't have known anything about it, okay? But if it doesn't happen in 4 hours, it's not going to happen, okay? So which is why it's very important if you're in the emergency room and you get a pregnant woman in a car accident, you clear her C-spine, make sure she's not actively bleeding to death, and get her to labor and delivery immediately, especially if she's having pain in her trunk anywhere, okay? Because what happens is, as that placental separation gets bigger and it gets more traumatic, it pulls that uterus off the uterine wall, and mom can bleed to death very, very quickly. And it's an incredibly painful scenario. They're rolling and yelling and screaming. It doesn't look like there's a reason for it. They're just in incredible pain. And it's pain that doesn't match the clinical situation. She got in a car accident and her arm hurts, but she's yelling and screaming and rolling in the bed. She's bleeding to death in her uterus, okay? And it's the only way to make the diagnosis is clinically. We have to put them on the monitor and watch the baby and see what happens. Because remember I mentioned that baby is mom's pulse ox? Okay? If there's something wrong with mom, the body is going to reject the baby in order to save the mother, right? And so with the blood volume, with blood not passing through the placenta very well, the baby is going to start to show signs. And so we'll get this mom with incredible abdominal pain. She may or may not have vaginal bleeding, and we'll put her on the monitor, and the baby's got a horrible tracing. And we know that's an abruption. And then we just say, well, can we watch it? Is it going to heal itself, or do we have to go to a C-section? Okay? Preterm labor. The number one significant morbidity associated with pregnancy is preterm labor. Does it hurt mom at all? No, it's just labor. It's just a few weeks early, but it hurts baby, okay? The vast majority of preterm births occur between 34 and 37 weeks, really close to the term, but not quite there yet. And it starts with a little preterm contractions. It starts very subtly. They contract more than 6 times an hour. They might get a little bit of bloody show. They come into the hospital, and they're 4 centimeters dilated already. Okay. Unfortunately, there's very little treatment. Oh, I forgot to mention fetal fibronectin. There's this wonderful test that we can run from the period of viability up to 34 weeks. Okay. 24 to 34 is a very magical time in pregnancy, okay? After 34 weeks, we just ignore it and let it happen, okay? But before 34 weeks, it's safer to stop the pregnancy or stop the labor if we can, okay? Because babies don't like being born before 34 weeks, okay? But there's this, during that magical time, we can do a biochemical marker called fetal fibronectin. Fetal fibronectin, you guys read anything about it? It's the glue that holds the amniotic sac together, okay? Between the amnion and the chorion, it's what makes it adhere. If a woman is going to go into labor in the next 2 weeks, that glue is going to break down and it'll be present in her vagina, okay, or in her birth canal. So we can test her vaginal fluid and see if there's any fetal fibronectin in it. If there's no fetal fibronectin, she's not in labor, life is good. It doesn't matter if she's contracting. There's no fetal fibronectin, she can't be in labor. Her chance of a vaginal birth, her chance of a birth in the next 2 weeks is less than 0.5%. Very good, a very good negative predictive value for that test. If it's present, it doesn't mean she's going to have a baby. It just means we're back to where we were before we tested. It means she's at risk of having a baby, but we don't know. Okay? They usually will couple the fetal fibronectin with the cervical length and see if there's any, if the cervix is shrinking and the fetal fibronectin is positive, she's at very high risk of going into labor. And unfortunately, there's only one thing that we can do, and that's delay birth in the hope of optimizing fetal outcomes, okay? We can't stop preterm labor, just like we can't stop a freight train, okay? It is barreling down the tracks, and there is nothing we can do about it. If it's going to happen, it's going to happen. It is fate. We can prevent it with good dental care and good prenatal care and avoiding stress. We can help prevent it that way. And we can slow it down, but we can't stop it. And if you ever heard anyone say, I was in preterm labor and they stopped it, they weren't in preterm labor. It was a false alarm and it would have stopped on its own. Okay? But the accepted wisdom today is that you can't stop preterm labor no matter what you do. Okay? But why do we want to slow it down? Okay, gives them a little bit more time. Now labor, does it last a week or two? A day or two. So what can we do for a day or two that's going to help the baby? Give them steroids, exactly. What kind of steroids? Corticosteroids, yep. We use corticosteroids. Betamethasone is the drug of choice. We give them 2 shots, 24 hours apart. And that helps the lung to mature, and it only works if the baby is born in the next 7 days. So if you give your betamethasone at 24 weeks and she delivers at 28 weeks, you wasted your opportunity. And you only get 1 chance. So they hold it until they know the baby's coming, and then they give the shot. And they hope he doesn't deliver, period. But if he's going to deliver, they hope he delivers within the next 7 days. Premature rupture of membranes, it's called PPROM, okay? It's prolonged premature rupture of membranes. But premature rupture of membranes, the definition is anytime your water breaks and you don't go into labor in the next 24 hours. Okay, that's premature rupture of membrane. But what we're talking about here is prolonged premature rupture of membranes, meaning when the baby is still premature. I think I mentioned it last week that it happens at like 18, 19 weeks, and it's almost always fatal. If it happens and when a baby is viable, they're going to deliver pretty soon, but they'll probably survive. Okay? We know it's ruptured membranes because she gets a gush of fluid from her vagina. Okay, we test it, we see it's amniotic fluid, life is good, we know what it is. Most times, if they're before 34 weeks, we leave them pregnant for as long as we can. Delay birth until baby is mature, or mom or baby gets sick, and if one of them gets sick, we move toward birth. Hypertensive disorders. You have a great article on Blackboard. It's ACOG's hypertension in pregnancy. And also, I'm going to, when we do our preeclampsia drills, I'll have the California preeclampsia protocol as well for you for next week. But know that hypertension in pregnancy is one of the big killers of pregnant women in America. And it's a spectrum disorder, okay? We can have a woman who starts her pregnancy with high blood pressure. Okay, that's called chronic hypertension. They either will or will not get horribly sick during their pregnancy. Most are pretty stable, and the preeclampsia, the high blood pressure has nothing to do with their pregnancy. Okay, but you can also have preeclampsia, Preeclampsia and eclampsia are pregnancy-specific conditions. They only happen during pregnancy. You cannot have preeclampsia or eclampsia if you're not pregnant or have just delivered, okay? It's purely a perinatal problem. So you don't have a woman, like none of you right now could have preeclampsia, period. It's not possible, okay? It happens from the placenta. And if you don't have a placenta, you don't have preeclampsia, okay? But preeclampsia, there are 7 theories to what causes preeclampsia. All of them revolve around the idea that there's some kind of disruption in the placental bed where it connects to the uterus, releasing some form of toxin that is bad for the mother, okay? The most common of the 7 theories is that it's an allergic reaction to dad's sperm, because dad's DNA is a foreign invader to the body. And we talked about how a woman's immune system slows down during pregnancy so that it won't recognize dad's DNA. Sometimes it recognizes it, okay? And when it does, it causes preeclampsia. The earlier preeclampsia develops, the more serious the disease, the more drastic the effects, the higher the chance of mother or baby are going to die, okay? Lucky for us, it almost always starts at like 38 weeks. We just deliver the placenta, life is good, okay? And that solves the problem for us. Now notice it's pre-eclampsia, because pre-eclampsia we now consider it a disease, but it's really not. It's a set of symptoms. The disease is eclampsia, without the pre, okay? It's kind of like the difference between pre-diabetes and diabetes. Does anyone know what eclampsia is? A seizure, exactly. It's actually not, it's not a seizure disorder like epilepsy. It's swelling on the brain causes a seizure. It's really increased intracranial pressure, okay? So eclampsia is an incredibly dangerous thing. It tends to lead to hypertensive crisis and stroke, and if it's early, it'll kill mom and baby. And then there's, of course, preeclampsia was superimposed on chronic hypertension. That's the one who had high blood pressure, who develops preeclampsia. They are horribly sick. And then there's the 2 benign conditions, gestational hypertension and transient hypertension in pregnancy. Gestational hypertension is a rise, an abnormal rise in the blood pressure, but it never creates any of the symptoms of severe preeclampsia. And then transient hypertension is usually white coat syndrome. You know, a woman comes in, she's nervous, we take her blood pressure, it's high. 10 minutes later, we take it again and it's normal. That's transient hypertension. And it means they're at higher risk for preeclampsia later, but they don't have a disease. All right, let's take a quick break. Can we take 10 minutes and then come back?
So it's a new topic.
That happened with Downton Abbey.
What's that?
That happened with Downton Abbey.
Downton Abbey sure did. Wait, yeah, that's what killed her. What was her name? Sophie?
No, it was Sybil.
Sybil, that's right, that's what killed Sybil.